This episode is brought to you by IndieBase, the smart, simple and budget-friendly electronic patient report system built for the realities of HEMS work and pre-hospital care. Whether you're a solo responder, part of a flexible team or working across a large organisation, IndieBase is the right solution for you. So it works on any device, laptop, tablet or smartphone, and crucially it runs offline when you need it the most. So born from trusted foundation of HEMSbase and built by the Medic One systems team, IndieBase combines a familiar intuitive interface with rock solid reliability. So from festival first aid to complex patient transport to high acuity critical care, IndieBase is ready for every pre-hospital scenario. So it integrates with all popular pre-hospital monitors and includes powerful case review and indeed clinical governance modules. So it's ideal for maintaining high standards and supporting services preparing for CQC registration. So there's also a dedicated patient feedback module, which when used alongside clinical governance supports continuous improvement and patient-centered care. So for those working across multiple organizations, IndieBase gives you a personal logbook that unifies your data and even integrates with your HEMS-based logbook. So it's quick to deploy, easy to use and built for the field. IndieBase makes electronic patient reporting simple wherever you are. So find out more at indiebase.net. That's INDIEBASE.net or head to the show notes for further information.
You're listening to the Pre-Hospital Care Podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, we're diving into the evolving role of ultrasound in pre-hospital care and indeed the management of trauma. So once confined to hospital walls, ultrasound has rapidly become a frontline tool really in pre-hospital care in both critical care and indeed in on-scene decision making. So in the episode, we're going to explore how ultrasound really helps us shape clinical decision making, but also understanding the physics behind ultrasound, like frequency and resolution, directly impacts what clinicians can detect from internal bleeding to a collapsed lung. So we're also going to move into the practical applications of ultrasound, breaking down probe selection and key sonographic findings for conditions such as pneumothorax, haemothorax, and or haemoperitoneum. So through case studies as well, we're going to look at the utility of ultrasound, really through case studies such as stab wounds, hanging, and traumatic cardiac arrest. We're also going to examine how ultrasound findings shape critical interventions in the field. So we're also going to ask the important question around training and competency. How much is enough? And indeed, can we ensure skills are maintained? And finally, we're going to confront the ethical and operational dilemmas of when ultrasound findings guide major interventions like thoracostomies, but also the ethical question of really informing decisions to withhold further resuscitation. So to do this, I'm joined by Mike Palmer. You'll have heard Mike on a recent podcast with me talking about rehabilitation. He's no stranger to the podcast. Welcome to the podcast, Mike.
Oh, hi, Owen. Good morning again. And thanks for having me back. And as you know, it's always nice to be here. And it's today to talk about my favorite subject, ultrasounds. So it's great.
Oh, that's fantastic to have you actually. Mike, I wonder if we could just really kick off actually and really just speak to the contemporary role of ultrasound in pre-hospital care management of trauma. Just, I guess, in a way, could you just maybe give us a brief potted history of its evolution in recent years in pre-hospital care?
So and taking it back, clinical ultrasound from the beginning really was based back in the 1950s, and it was only until a further kind of 50 odd years until it was brought pre-hospitally. And even now, that you've in the last even year, 2 years, ultrasound devices are we know the size of a tablet, but also having like even more advances even in a short period of time. So even like talking, auto labeling on devices pre-hospitally, we'll go into it, I'm sure of it, but the, auto B lines, thinking of how many mils are in the bladder, it's got to like another level really. But an increasing kind of valuable tool, and it's just it's a bit like your blood pressure cuff, your SATS probe, your end tidal. It's another tool there that you've got to have the full kind of clinical picture and the assessment. And I think that's what's kind of really kind of the trend throughout this pod really is just it's a tool, and that's got to be mindful of that, and it's just not a standalone assessment modality.
Yeah, indeed. And as you're saying, it's starting to become a lot more recognized as a standard of care. I'm not yet sure it has become a fundamental standard of care, certainly not in general primary practice, but becoming far more accepted, like you said, it as a suite of diagnostics and or indicators that you can start to diagnose on. Could I get you to speak to really just in a way a brief explainer just to help us achieve a baseline, Mike, of just the physics of ultrasound, especially sort of frequency and resolution, and indeed how it influences what we can see in trauma scanning?
Yeah, I think definitely understanding this aspect kind of makes you think about the practical points of view about scanning patients as well. But no, yeah, ultrasound, are waves or sound waves really that are frequencies way above what the human hearing can hear. But in medical imaging, we technically use kind of frequencies of 2 to kind of like 15 kind of megahertz. But 1 hertz equals kind of 1 second, and these probes can emit then 2 to 15 million waves per second. But that's constantly when you've got the ultrasound device itself, the majority of its time it's kind of waiting in kind of waiting or like a receiver mode. So these ultrasound waves kind of go out and they kind of reflect on bones, organs, fluid, or whatever you're scanning, and it takes that time to come back when that image is coming back to the ultrasound probe itself. It kind of generates this kind of like 2D images, as we already know. But these ultrasound devices or the probes itself have got these kind of lots of kind of piezoelectric crystals. These crystals kind of vibrate. In other words, they're converted from electric magnetic energy to mechanical energy waves. And this kind of these kind of how it kind of generates from this electrical to this kind of this, as I said, this 2D image. Frequency, does it matter? Well, definitely it depends on what your goal is with your ultrasound device. Whether you've got it. We're talking today primarily about trauma, but do we want to use it for arterial access or intravenous access? So for that particular, we want a certain probe with a higher frequency. The higher frequency gives you that kind of like the finite detail of putting that kind of the needle bevel into a vessel. If you had a lower frequency probe, that would go deeper into the body to scan like an organ or a hollow kind of retrograde in the abdomen, but it wouldn't be so good for getting IV access. So it depends. So yeah, frequency is really important. Have the resolution to be good and the probe selection as well. So yeah, so to explain is you've got three typical type of probes. You've got your linear probe, which you've got that's for primarily for chest scanning. So looking at the for haemothorax or pneumothorax, that's we used for IV and access. You've got the phase array probe, which is a bit smaller rectangle, which normally that's for looking at cardiac echoing. And then you've got the curvilinear, which is kind of a longer rectangle, which is slightly kind of bent in shape as well. And that's when you kind of look between kind of rib spaces as well. So yeah, probe selection is really quite important. But, you can get some devices on the market where one probe does it all, which you can do that. I agree. But for the best image quality, it is more useful to, especially when you're a beginner as well, to kind of select out the right probe for what your goal is for using the device for.
Yeah, indeed, indeed. Could I get you to speak to just the reliability? We're starting to see the adage and evolution of people scanning and going straight to the operating theatre. That maybe isn't necessarily happening within the UK right now, and it's like you said before, more adjunctive rather than a definitive tool. But could I get you to speak to reliability really for detecting things such as haemothorax or haemoperitoneum in the field, and indeed I guess in a way to your own practice, how these findings are influencing management decisions.
It's definitely it's a really good question because if you ask me, or what's the evidence behind ultrasound, it's really hard because if you're with a patient who can get intravenous access, and then you've got the only option is oral or sublingual or other types of pharmacological agents. you to come along and you get some IV access with a with an ultrasound, has that been assessed really? But no, when you look at, in detail, it's, a lot of ultrasound or pre-hospital care ultrasound now is a lot of retrospective data, and it gets a bit muddled then as well with the A&E data then as well. But even like one published, I'm sure you can put it in the show notes, that it concluded that that fast information pre-hospitally significantly hastens kind of like door to needle time or door to CT time. And I think like it's a really good point there, because I feel, I'm in a very privileged position where when I take my patients to a major trauma center, I speak to the CIC, the consultant in charge, or the TTL trauma team leader directly. And I like to think if I spoke to them and I said, this patient's not a code red yet, so I'm not kind of transfusing them. However, they've got normal vitals, but they've got a positive fast. I'd like to think that that TTL's kind of ears would kind of prick up a little bit and think, oh, okay, here we go. There's something brewing here in the background. And it's that concept of having that information passed over and thinking it might change, maybe not our practice yet, but it might change your practice in an hour's time. And then, the same paper as well, published in the injury, said that, it doesn't reduce scene times. It can kind of change management on triage, transport decisions, and as I've been saying about hospital notification. But you just, we'll go into it. But when you think that you've got a scan and you're scanning somebody, and you don't want to be scanning them and thinking, oh, they're negative, okay, they're okay to go to like the local trauma unit. You just need to be really careful of the decision you're making, and be aware of your own confidence and competence with that scan. And when we look at it as well, that it was a lot of the time that, in another paper is saying that ultrasound particularly has got really high specificity, but the sensitivity is not as good. So it's really good at picking up when people are really truly positive, but those other aspects when it might need like some serial scanning. So it might not be negative, that might not be positive now, but maybe in 45 minutes, an hour's time, it might be positive. So you just need to be quite careful there. And also, we've kind of gone into another kind of subject with kind of governance, but when we look at ultrasound scans and when you do scan patients, especially for example in the right upper quadrant, we need to be kind of like fanning, so really taking that whole quadrant into and videoing that as well, because it might look completely negative, but then you kind of fan through and there's the whole lot of blood. So, but yeah, so it's interesting. It's hard though.
Yeah, indeed. No, absolutely. There's lots to go at actually. We have another episode where we're going to talk about the more of the governance aspect, which is extremely important as well. But something you said initially, which really, I just wanted to double click on really, which is around it is an adjunctive tool, which is it's a part of a suite of tools, but also together with a clinical picture. Because to your point, if there's a negative scan, but the patient is diaphoretic, pale, just the respiratory rate is starting to be elevated. It's there's you know it there still needs to be, just because it's you can't rule, it's a rule in, not rule out. So just you can't rule things out just because there's a negative scan. You can rule them in if you're seeing pathology in front of your face on the scan. But to your point around not being overconfident in the scan, it's an adjunctive tool, which is a confirmation tool, not necessarily a definitive tool. We're going to jump into some case studies, but did you have anything to say on that?
No, no, yeah, and I agree, and I think again, big fan of ours and the pod as well. Dan Nevin, he's definitely, we've kind of picked up with LAA that you've got scans where they've been completely negative and then it has been positive later. And that's what's, those serial scans has been made a point really, that especially in the kind of the governance loop really as well.
Yeah.
But going on the question regarding haemothorax as well, the sensitivity has been up to like 92% and a specificity of 100% of detecting haemothorax after trauma. So we're looking at those percentages the same as hospital data. So, but yeah, we'll go on with governance a little bit later on. but it can be just as good.
So let's just jump into a few case studies. One, something that you would see certainly within London and elsewhere quite frequently would be a stab wound to the anterior chest wall. Reaching for the probe over the stethoscope. What's your preference there? Is the ultrasound probe one of the first things you bring out of the bag, or do you kind of, is it more a later adjunct?
Mm. I don't know about you, Owen, but I feel like even years after listening to people's chests, I don't feel I'm still not quite good at it really. And I don't know. I think I know you've got your crewmate talking, then you've got the patient talking, you've got your diesel engine running. It's and then you have a listen, and then you think, oh, you think of something, or you think what you've listened, and then you have another listen, and you're not quite sure. And it's fine to probably do that as a part of a clinical assessment. But then when you're trying to judge a question on, an examination, and then maybe to hand that over in hospital, I think it's fine to do that. But then when you get to a point where you want to put a finger in somebody's chest, do a thoracostomy, for example, post RSI, you're making, those decisions. Then I think you've got to be really sure. Um, so yeah, I still carry a stethoscope in my pocket. I'm sure I will for many, many years. But I do feel that when you've got an ultrasound in your bag, I'm going to be selecting the ultrasound if I'm honest. Yeah.
Yeah, indeed, indeed, absolutely. But just changing things slightly. So in a flank stabbing, so, with relatively stable vital signs, what prompts for you the use of ultrasound? And indeed, do you use it in a way to rule out sort of life-threatening pathology? Are you kind of using it in the ambulance sort of once or indeed in the helicopter if you're loading them into the helicopter, or does it come out on scene? What's your application there?
I think no, I think we've you definitely spoken about this on the podcast before about the work they've done over in Bristol regarding the stabbings that they're increasingly having, same obviously across the country, and their kind of guidelines of staying the minimal time on scene. And we definitely need to be aware of that, and we're always conscious of. And I remember the definitely when I always kind of go arrive on scene, I remember like, the handbrake off time and that handbrake on time, the handbrake off time, and making sure that that's kind of the minimal time as you can. So we can't get muddled with, having lots of tests and done where ultimately we need to be making our way to hospital. So I think, yeah, going back, it's that global assessment, really, isn't it? Is the patient, as you said earlier, is the patient sweaty? Are they speaking in full sentences? What's their SATs doing? Have they been, have they ran for half a mile before they got into the back of the ambulance? That sometimes they definitely have, and I've definitely been in that circumstances where they've kind of quite frightfully kind of run from their life, really. So it's that global assessment. But if you've got time, I've definitely sat in the back of an ambulance with my seatbelt on and scan patients. That can be done, and I feel like that time between, whether you work in a rural area or in more of a metropolitan area, you have got that time in the back of the ambulance, and a lot of the time, it is a bit of like holding your hand, holding their hand, and doing the bare minimum at that time. But sometimes, and what I've kind of learned from kind of my journey is having that time to scan patients. And I feel that I've scanned so many patients who've got normal pathology, and that's going to help me kind of go forward and be confident when I scan patients going forward now. So I think I've kind of gone down a bit of a rabbit hole here, but no, I just feel like it's the global picture, Owen. Yeah.
Yeah, indeed, indeed, absolutely. And to your point, Mike, and that's front of mind. It's reducing time on scene. A lot of these interventions can be done, and or diagnostics can be done en route, to guide treatment. Absolutely. So just a really tricky one, actually, Mike. I'm going to throw at you, which would be around the case of hanging, and having spent a long time in London myself, and yourself as well, understanding that hanging is spectrum of pathologies, it's not necessarily definitive. That's not to say it hasn't got a definitive endpoint, or B, a lot of patients are in cardiac arrest, because that is truly the case. But actually, the more you attend hanging patients, the more you realize there is, partial hangings, or, attempts which aren't fully fledged, or indeed there's such a spectrum. And actually that can lead to some very difficult, either peri-arrest, post-arrest, hypoxic agitation, lots and everything in between, really, which is really, and extremely emotive, which is another extremely difficult factor to take on board. But speaking around lung ultrasound, in to interpret ventilatory difficulty, really, sort of venous congestion which can occur within these cases. Could I get you to speak to just learning points we can draw out from managing hypoxia, and indeed what ultrasound might show us?
Mm. I think if you're in a situation where you've got somebody who is in return of spontaneous a return of spontaneous circulation, and you've got them on a ventilator. In a lot of services, might not be in that situation, but it's going along the other lines of, people might have heard of like the DOPES kind of acronym. So if you don't know, it's the displacement of the endotracheal tube, obstruction of the tube, the patient, if they've got a pneumothorax, pulmonary edema, equipment, or kind of stack breath. So if you're going to go along that kind of acronym, but then you're still struggling with somebody on a ventilator, whether we need kind of like titrator kind of settings, yes. But if you've got somebody who's got low sat still, we do that. Does that patient need some suction, for example? So they kind of aspirated lots, and then by looking on the ultrasound, or using an ultrasound machine rather, you can have a look at whether you've got excess fluids, so whether you have something called B lines, for example, and that's a sign really of more kind of congested kind of lung pathology, really. So I've definitely kind of used that in cases on the way to hospital to kind of scan the patient's chest and notice lots of B lines. Whether we should increase the PEEP a little bit on the ventilator, should we decompress the stomach? And it's again going back to the other point as well, is that looking at that global picture, and again using that ultrasound as a tool.
So just looking at traumatic cardiac arrest for a second, Mike, and the adage of the hot algorithm really comes into play, and has done for a long time, around the use of pleural drainage as a prerequisite. So not historically not really scanning the chest, but just facilitating pleural drainage as a reversible sign of a haemothorax, or indeed a pneumothorax. Could I get you to speak to really how ultrasound fits into that picture to complement the clinical assessment in traumatic cardiac arrest, and in a way guide the utility of thoracostomies? Do you, and the personal question really would be, do you use it before you enact maybe a hot algorithm on a traumatic cardiac arrest?
Yeah, good question. It's that whole thing of that, clinicians follow these algorithms, but they should really kind of decide where they're going to go. It's really hard when if you go to a traumatic cardiac arrest, and you've got somebody had needle chest for thoracentesis already. Should you upgrade that to a finger thoracostomy? Is the pathology or the mechanism there to kind of fit that picture as well? I would be, if I'm totally honest with you, I'll be sitting on the fence whether I would be getting out the bag straight away, if I'm totally honest with you. And as we know from Zane Perkins et al., their recent paper on the tamponade pathology that they've been having, it's if you've been somebody who's got that injury into that chest or the upper back, and they're in a PEA, I think they're going to elect really to go straight to doing that thoracotomy. And they've learned from that paper that they have somebody goes into arrest with an enhanced team there, their outcomes are a lot better. Should we be trying to make that decision, try scan? It does take some time, but I don't know. And I think if I'm honest, I'll be carrying on and doing those, interventions quite quickly, really, if I'm totally honest with you.
Yeah, indeed.
But I'm not saying never say never. There's been quite well, I wouldn't say a famous case, but there's that the blunt thoracotomy that Wales did a number of years ago, and that was a patient that fell from height. It's in the literature. There's a case study on it, and I can put that in the show notes as well. But that was definitely found on ultrasound before they did the whole thoracotomy. So yeah, sit on the fence, but I don't like to, but I am.
No, indeed. No, absolutely, absolutely. And to your point around the, bringing interventions to the fore because they've reached this end state of traumatic cardiac arrest, not negating a pelvic binder or indeed, like you said, oxygenation, pleural drainage quickly and almost not necessarily maybe elongating that. But to your point around understanding that actually within traumatic cardiac arrest, it's what the really key interesting differentiator in my mind was that thoracotomy is an intervention, as you were saying before, for tamponade. It's not necessarily an intervention now for traumatic cardiac arrest, and it's
Hmm.
I think speaking to Zane, speaking to Mike Christian, what I realized was that actually we've got to, and to your point, Mike, we've got to be a lot more purposeful around the intervention targeted to the pathology. So actually, have they got a tamponade? Because the intervention is a thoracotomy for a tamponade, because we know that actually patients don't do well. There's a very poor survivability from a hemorrhagic cardiac arrest, which receives a thoracotomy, and actually it's a really targeted intervention for pericardial tamponade. And actually, it's nice to have that focal appreciation that that's actually what's killing the patient. We are going to do a separate podcast on training and just on governance and on interpreting scanning and and just everything around the kinesthetics of feeling the probe on different patients and how that changes per patient and the utility of just scanning more patients than maybe you need to just to get that level of comfort and indeed appreciation. But could I get you to speak to really what level of training as a baseline and or as a standard would is beneficial for pre-sport clinicians and maybe in a way how services could maintain competency over time for high acuity skills and or scanning in critical care situations.
Mm. I think it would part of that question to break it down really is at an individual level as well as a system or service level as well. We need to be aware of what's your your SOPs and your governance into that service that you work for. But if there's lots of courses out there. There's the level one courses. They're typically normally a 2 day course. Some of the better ones they normally have patients that come in have got triple A's already, and you can go and kind of measure them as well. And but then for example, the one I went to on originally that I was the only paramedic in the room. So there was 25 kind of house officers or foundation year one kind of doctors really. But I think that what that course did kind of made me realize is that understanding of the physics, the basics, how to scan, and I think that's the hardest bit really. You understand how it all works, but then you all of a sudden you go to your first patient and you can't get any windows, and you're like, well, I've done this, but it's so hard. And this is what's really hard about this government aspect, because you go on the course and you think, okay, now you want to be accredited. Okay, so where are you going to go to? So, and this is where the massive predicament I was, and I still am really, of, how do you get that accreditation? And unless you work in an in-hospital environment, it's really hard to get this because you've got no one over your shoulder looking at your scans on a day-to-day. Even in people who are in a really kind of luxury kind of situation where we're always working with a doctor or a senior clinician. They're not always there. You don't get the breadth of scans you need. And if you look at the RChem guidance, I haven't looked at it recently, but I remember it was saying something 25 or 50 scans, per area, and you need to add that up, and then you think like, well, if I do all this, it's going to take me probably about a year for me to get accredited. And then you look at like there's PG certs out there as well. I don't know them in detail, but you understand the academic side, but then do you get the hands-on practice then as well? And if you do get the hands-on practice, is it the practice that you're going to do when you're on your own? So are you going to just be go into an outpatient kind of an ultrasound and use it in hospital? It won't be the same scan or the same ultrasound device. Then all of a sudden you're trying to scan somebody on a bedroom floor and they're cardiac arrest and you've got the Lucas on. And this is what we've found really in my service is like, how do we kind of replicate that, RChem guidance or, that type of governance into our field really. So yeah, I'll go on to it again. I can carry on talking about this really, but I don't want to go into too much detail for the next podcast. But I feel that you can definitely learn lots online, lots from textbooks, but definitely go on a level one ultrasound course to kind of start your journey.
So just looking before we come into land, just the final few questions. One would be, Mike, around really, we've talked about this and we've notion towards this around balancing the speed of decision, that extra layer of information on scene versus that extra layer of information en route to hospital, when there's a critical care patient and, learning when to do the scan on scene versus when to do it en route. Um, it's different in your service when the transport times are elongated. It might or might not be a road ambulance. So actually, if you're putting them into the back of a helicopter, you don't necessarily have 360 access. So understanding whether you need to do formal pleural drainage with the adage of ventilation, artificial ventilation. Yeah, could I get you to speak to, because there is this grey area where you can, especially in London, you have the advantage of being so close to major trauma centres. Most things can be done en route. 95% of the time, that's within an ambulance. So actually, I'm not saying you always have 360 access, but you've got maybe more room to manoeuvre, and it can be extremely tight in the back of a helicopter. My question is really, do you? What's the interplay for you with extended scene time, sorry, extended transport times for you? You might be flying a patient an hour and a half. Do you just take that extra 5 minutes to get the ultrasound out, or does it come out the majority of times in the helicopter?
Mm. I think when you were chatting then, Owen, I was thinking of these lots of different scenarios that I've been in where I've literally talking about this subject and thinking, what do we do? Do we phone a friend? Do we yeah, and it's hard. But I think you do need to step back, assess, think before you make these decisions. And this is what makes more of a rural service very different to an intercity service as well. And also that the sometimes an ultrasound. I remember two clinical examples of that. The patient had so much surgical emphysema, the ultrasound was completely futile because it didn't show anything. But we kind of know at the diagnosis anyway. So I think you just need to think again. What I kind of say to people sometimes: what does the patient need now? What does the patient need in 30 minutes? And what does the patient need in 60 minutes? And if you do need, we people argue the use of pre-hospital chest drains. There is definitely we do all of them all the time. They're not as frequent, but we do them. But then also on the other contrary is that can we get away with it? And it's a cleaner style, better to do it in hospital, and people would kind of sit on both sides of the fence with that. And I respect those both decisions really. But to answer the question, no, step back, reassess, and think really. But then on the contrary to that as well, sometimes we think, we're not too sure, we're going to go by land. I know we've got that opportunity to fly, but hey, it might save us sometimes 10, 15 minutes. But if we don't do that, we can go on the back of an ambulance and we can draw up the blood if needed. We can pull over and do the RSI if needed. So sometimes it's not, sometimes putting them in the back of the helicopter is not always the best decision either. Hope that answers the question.
Yeah, well, it does because I think fundamentally it's slowing down to speed up, and as you were
Mm,
saying, just taking time to understand what the patient needs, and also giving yourself off ramps. And an off ramp would be, like you said, going by land rather than by air, because you have chance to pull over, you have chance to really change the treatment plan if the patient's pathology mandates. So it absolutely does make sense, and actually. There is, and this is a really key thing you've notioned towards this is, there's a high frequency of stabbings in the UK in various areas, and there's also a trend upwards in Europe and in the US, and keeping on-scene times to a minimum is absolutely key, but still applying some critical thinking to that patient ahead of time, and not just by rote rushing the patient into an ambulance and rushing them to hospital, really thinking what they need, um, both now, 30 minutes and 60 minutes, and giving yourself these off ramps. I think, like you said, it's critical. And if there is any complexity, sharing that decision quickly, breaking the decision down, as you say, reach back is key if need be. Not at the detriment necessarily of the patient, but really starting to share that decision and giving yourself the off ramp opportunity. The last question is probably the most tricky, but something I was certainly within London doing on a frequent basis, both within trauma but also within medical cardiac arrest, which is using ultrasound as an adjunctive triangulation tool. That's a word salad, but I was using it with other diagnostics to not necessarily withdraw care, because care hopefully endures to the wider scene and wider family, but certainly to withdraw resuscitation, um, using it with the ETCO2, using it with the ECG, but also certainly using it to really understand what the cardiac activity is doing in cardiac arrest. Is it, my question on the back of that, Mike, is it an adjunctive tool that you're using now on every cardiac arrest?
hmm. I think you alluded a little bit with your, with your question as well, isn't it? That you don't roll somebody recognition of life extinct on just the end tidal due. It's that it's the adjunctive tool, as you say. Um, Good question. I think 9 times out of 10 we're probably getting it out of the bag, yes. But is that kind of those stats probably a bit not quite right, because I'm probably in a service now that I get selected to go to certain cardiac arrests. I know we don't get dispatched to all of them or the majority of them. It's a CCP, critical care practitioner, really kind of looked at that cardiac arrest and thought that we're there to add something. And also, we're a lot of the time now we're 20 minutes, 30 minutes behind the ambulance crew as well, especially with the flight times or the journey times, really. So we're there already, really, is to provide an enhanced care potentially. So I think to answer the question, yes, I do, but I think it's hard to say we should get out every time because I don't go to every kayak rest. Does that help? Yeah. I don't know whether you could kind of add more to that, but I don't. Yeah, I do like to, and then also it's that thing as well that if you're scanning those patients as well, it's getting that. I don't want to say practice really, because it's not practice at all. But when you are scanning, going back to governance as well, you're scanning lots of people all the time. You've got that, yeah, that hands-on kind of practice really to kind of get those images really. And but we need to make sure that that time off the chest is minimal, and we definitely have protocols with that. And we probably go into the next podcast of how we kind of go along the lines of those protocols of minimal time off the chest. For example, you're not the person doing chest compressions. The ultrasound device has already got gel on it. It's all, you don't assess the chest or the ultrasound, the echo, whilst you're scanning. You save it and then you come away. So especially with our training, we have these 5 second periods of scanning and coming back and off. So it's is a bigger decision really, and it can have some consequences. And definitely in the guidelines, it does say about keeping, chest compressions, defibrillation is still right up there, and it will be, I'm sure, for many, many years.
Yeah, indeed, indeed. And we'll go into the next podcast and look at, like you said, the governance. So just reviewing scans in critical care and what we can learn from retrospectively in slow time from reviewing scanning, just according to what the interventions we did on scene and learning what we maybe could have done, how it guided our decision making, and we'll tackle that in the next podcast. Listen, thank you, Mike. It's been fantastic to catch up with you, and we'll see you shortly for the next episode on the podcast. Thank you, mate.
Thanks, Owen.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.